Good afternoon, everybody. We are now live as we typically talk about our three ways to wellness with nerve flow, exercise, and water. I'm so excited to bring you today's guest. A lot of you are out there suffering with pain, facing surgery. You're only getting one opinion on things, and maybe you're at the wrong type of doctor. So, we're here to give you some more information with my friend and colleague, Dr. Nathan Kreider.
All right. Yeah, thanks for having me. And so my specialty is maybe a little different than someone you've seen before in the orthopedic world. It's called physical medicine and rehabilitation, also called PM&R or physiatry. And that's a non-surgical orthopedic specialty. So we do pain management injections type things, which classically is steroid injections. So a lot of you probably had cortisone shots before for arthritis or tendonitis as kind of the standard of care for sprains and strains and degeneration, because it happens to help for about 3 months for most people, that anti-inflammatory, um, even in situations where they're not necessarily inflamed. And so there's other aspects of pain besides just acute inflammation that steroids can kind of cover up for a while. And so um, that's kind of a lot of I was trained in was more ultrasound guided steroid injections, fluoroscopy guided, X-ray guided, spinal cortisone shots, epidural steroid injections. Um, but when I was in residency in Charlotte, we rotated through the VA hospital in Salisbury, where they were actually doing prolotherapy for some of these chronic injuries that weren't responding to pain medicines, anti-inflammatories, cortisone, stuff like that. Um, and the veterans were getting great relief with that, even if they've had it for 50 years. So that was kind of eye-opening to me that there was this other option that wasn't really being talked about in most orthopedic clinics just because it's not covered by insurance. And so a lot of what we do is guided by what we're paid to do. And so we don't talk about things that are not part of that. So I had to kind of seek that training out myself. Um, Through the Hackett Hemwall Patterson Foundation, through as well as just through one-on-one training with doctors that were doing regenerative medicine injections, is what that's called, where you're actually injecting into tendons, ligaments, joints, something that can help stimulate that healing response, whether that's that prolotherapy they were doing at the VA, or whether that's some of the stronger treatments that are available now, such as platelet-rich plasma or bone marrow concentrate stem cells. So that's all kind of part of that same idea of trying to stimulate the body to repair itself rather than covering up a pain, kind of a new paradigm.
Yeah, so we're going to break all that down for people that don't understand that. And this is in just
Mhm.
maybe an understatement, but in my sales life, I would call on physiatrists. And the way I would explain it to others is they're like a physical therapist on steroids. And let me tell you, Nate and I sat down and talked about all things spine and nervous system for an hour. We probably could have kept going on for hours. And we're going to break that down and see how it could help you with what's going on. I know you're not from the Asheville area, Nate. Where did you grow up?
I grew up in the suburbs of Chicago, and then went to college at McAllister College in St. Paul, Minnesota, where I ran track cross country and cross country skied, um, and then went to med school at the University of Minnesota. Came down here for that residency program. I talked about it at Carolina's Rehab, now part of Atrium, in Charlotte. And then I've been with Regenix since that time. So Regenix is this group of physicians, international group, that have been kind of the leaders in this regenerative medicine space. So using platelets and stem cells and stuff to stabilize joints is a big thing too, in addition to kind of treating that arthritic process. So they call that interventional orthopedics, kind of like interventional cardiology replaced open heart surgery in a lot of ways. You can go get stents or you can get valves replaced, through your blood vessels, as a minimally invasive kind of way of getting at that. Interventional orthopedics is the same idea where we can do targeted injections using image guidance into all these little substructures that stabilize your area. So if it's your knee, it might be your MCL, your ACL, your LCL, your pes answering tendons that come in and get kind of loose when your MCL is loose. Those muscles can kind of get overused and cause you some pain on the inside of your knee. Um, we are actually treating all of those substructures to stabilize the knee, in addition to putting some cells maybe in your knee as if it were a steroid shot. Um, or when we're doing like stem cells, we'll actually inject them onto the cartilage surface and kind of drip those cells because they're sticky onto that area that's losing cartilage. Has been found to be more effective than just squirting it into the joint fluid and hoping that they find their way to the cartilage loss.
For
Um,
people that don't understand what that means, the old school orthopedic doctors used to call it a pistoning approach. They would just take a needle and start pistoning it all around and go for broke. And as we talk today, Nate's going to talk more about his specific talk, but sounds like you valued your health as your best asset, Nate, growing up as an athlete, and then turned that into a medical degree. What was the shift for you? Maybe not going the traditional route of medicine versus into physiatry. Not that that's
yeah,
non-traditional in any way, shape, or form, but what choices did you go, like not going like traditional orthopedic route versus physiatry?
yeah. So yeah, I mean, as an athlete, I was always interested in like why one person gets injured and another person doesn't, like on a team where we're all doing the same training regimens.
Exactly.
Um, and I think a lot of that is kind of some of the muscular control around those joints. You know, you can put in 100-mile weeks and just be just fine if you have kind of a good form, good control, or if you're kind of weak in certain muscles and then you're overusing certain tendons or overstriding and pounding on your meniscus, you can, destroy your knees doing half as many miles. So that kind of idea of thinking about what's called the kinetic chain, meaning how one area's dysfunction will cause dysfunction above and below it because each of these areas is moving a little bit as you move. If your knee rolls in, if your foot rolls in, it causes your knee to dive in, which causes out pain on the outside of your hip. So that whole thing is all connected. Um, that was something that I was very interested in high school and college. And then you get to med school and you look at how, you know, your training goes and you end up being very super specialized in orthopedics where, don't talk to me about your hip. I'm the knee guy. I just replace knees. Or you can talk to my PA and they'll put a cortisone shot in it. Um, Nobody really wants to talk about how your back affects your hip, affects your knees, affects your foot, except for this physical medicine specialty where they do kind of look at how everything moves. Um, and so that was part of it. It seemed like a lot of it was kind of chasing after whatever hurt rather than treating kind of the root cause of some of these things. And I've now kind of realized from having done so much of this spine training that the back is kind of the center of a lot of these things as far as nerve activity to your muscles that give you stability, or ligament stability, which holds your bones together so that your muscles don't have to be tight all the time trying to hold you together. Because people come into me saying, my back's really tight. I throw it out and then I'm just locked up and can't move for a week. And I would say, and then we look at their MRI and they've got, bulging discs and arthritis in their facets. And we would say that both of those MRI findings are downstream effects of ligaments being loose. And so if your ligaments are loose, your bones are just shifting on each other. It's like two blocks of wood just rubbing on each other for 50 years. Um, and it's no surprise that that shears on your disc and causes your disc to bulge, or that those joints are jamming on each other and you start to get arthritis on them. And then you're moving around too much, your muscles sense that extra movement that your ligaments were not holding you together well enough, and then your muscles lock up, and those muscles are tiny. They're not made to hold you together, 8 hours a day or 16 hours a day. They fatigue, they get sore, they get tight. So the physical therapist can work on training your muscles, and so they can strengthen your transverse abdominis so that you're not, or your glutes so that you're not in a posture that's overusing those little muscles. You want to be using your big muscles instead because they don't fatigue as well. But ultimately, you can't train your ligaments. There's no exercise to tighten a ligament. It's passive. It just connects a bone to a bone like a piece of duct tape. Um, and historically, there wasn't really another way to do that. Then you could be in a brace, a brace will hold you together, but then you're not really using your other muscles, and back braces ride up. They're not great for backs. Um, and so that's why they just put cortisone on, hope it covers up your pain for a while. But now with regenerative medicine, we actually do targeted injections into those ligaments that are loose to try to stabilize the back so that your muscles are not having to lock up to hold you together, so that when you do a twisting, movement in the yard, that you're not suddenly going into spasm afterwards. That's kind of what regenerative medicine is really unique on for looking at instability and laxity.
Yeah, well, I'm glad you bridged that gap for us here. Regenerative medicine, for lack of a better term, I'm going to call it breakthrough. And I'm going to say that because look at your mindset, right? How you were wanting to connect the whole body to something, but you're being imposed upon you that the knee's not related to the hip, right? And that kind of didn't resonate with you, and led you down to
Yeah,
this path.
you train so much in your one surgery that you repeat that surgery all day, every day, and you're just looking at someone, are they a candidate for my surgery? And the answer for elective orthopedic surgeries is yeah, if you have an MRI with degeneration and you have pain that didn't get better with a cortisone shot, you're a candidate. You could get a knee replacement, put you on the schedule next week. Does that mean that you have to do it? Does that mean that that's the only way that can make your pain better? Does it mean it's necessarily the best thing for you long term? Like, not necessarily. But the question that's presented to the surgeon is, are you a candidate? Should you do it, or could you do it? And the answer is yes. And so if you're just coming from as an uneducated kind of healthcare consumer, you're saying the surgeon's telling me to get a knee replacement, I must need it. But that's an elective procedure, and a lot of people have severely degenerated knees on x-rays, and they're not always painful. So you can be told you need a knee replacement and wait 15 years and be pretty good, and then and then have it start to bother you, and then come see me and put stem cells on it and never get the knee replacement ever. Potentially hips are a little different. They tend to progress to be more severe more quickly. So usually if you're limping into your surgeons with a bone on bone hip, usually that's a hard one to just limp around on. It doesn't tend to come and go like knee pain does, and tends to respond pretty well to a hip replacement. So for those folks, we'll often recommend, or if it's bone on bone, to go ahead and do the replacement. But certainly spine surgery is one that is really, in my book, only do I send people for surgery if they're developing weakness down the leg because they're pinching on a nerve so badly, or severe debilitating pain down the leg that did not get better with conservative care. But if it's pain in the back itself, back surgery does not help that. Um, and even a lot of the burning pains down the leg, radiculopathy, can get better with chiropractic exercise, time, or regenerative medicine. So it just depends on kind of how you look at it, whether something, you just have to remember elective surgeries are just that there's never a situation where you have to get a surgery unless you're developing neurologic weakness.
Yeah. So Dr. Nate here is dropping truth bombs here, people, and this is kind of why we wanted to have him on the show today. Number one is you got to consider the source of the information, and if someone does something all day and that's all that they do, they're not wrong, but are they right? Especially when it's considered elective surgery, and you may want to have someone that has a better full body approach, like someone like myself or Nate, to give you a second or third opinion, so you can make a well-informed decision. Because I think Nate will agree, no surgery is minor unless it's somebody else.
Unless it's somebody else, that's right. And the only back surgery that's indicated was the first one. The idea being that you needed that fusion for your back because your disc was just crunching your nerve so badly that your leg was giving out on you. Fine, nothing else worked, you had to do it. But then that level doesn't move at all, and you're still moving. So the levels above and below it end up moving extra because you have a whole string of little joints that are all supposed to move a little bit. And so you end up wearing out that adjacent segment, the segment next to the one that you fused. That's called adjacent segment disease. And then you end up blowing out that disc and needing to extend your fusion. And so it's not uncommon to see people have multiple fusions, multiple back surgeries, because they've disrupted that whole chain of how things are supposed to move. So that's one of the jokes. It's the only
Yeah.
one that was indicated was the first one.
Yeah, I thank you for sharing that one. I'm going to add that to my playbook. Being this former spine device rep, adjacent segment's a big deal. And for years, they would just stick an implant in someone and hope for the best, whether it's a one level fusion or a couple levels. And why would some fail, not the others? And there's even failed back syndrome out there. I'm sure you've heard of that in the literature. I'm sure people are coming into your office talking about that. And if you don't get them sagittally balanced, it's going to create more pain generators for them. So this is where we're trying to impress upon you people. You still want to, there's no substitute for proper joint motion, and you want to exhaust all avenues before you get something like that. Because if you don't, and the surgery doesn't work, you're going to kick yourself if you just did the surgery and didn't do other things.
Yeah.
And can you talk to people a little bit? You brought this up with the kinematic chain and the difference of like a cortisone shot versus regenerative orthopedics. Can you elaborate on that a little bit? We were talking about the difference of the procedures. So, a common person will come to me, whether it's knee pain, hip, or even back pain, and the standard is like, 3 cortisone shots.
Yeah.
And then if that doesn't work, PT and surgery. But we're talking
Well,
about something.
hopefully they at least did the PT before the cortisone, but yeah, so it kind of depends on what area you're talking about treating. So for like arthritis, you're talking about more the cartilage and the inflammatory signals within the joint. The idea is put a high dose cortisone in there to calm down the pain for 3 months and hope that by the time it wears off that it doesn't bother you anymore, as if you just waited it out 3 months, basically. That's the situation where it can help with arthritis. The downside of doing that is that steroids are toxic to your bone, your tendons, your ligaments, your cartilage, and your stem cells, in a dose dependent way. And so when we put those, 40 milligrams of cortisone in your joint, they've actually shown like a randomized control trial of doing cortisone every 3 months for 2 years versus saline every 3 months for 2 years. And at the end of those 2 years, the pain was the same in the two groups because the cortisone helps for a couple weeks and then wears off, each time. But the cartilage was worse in the group that was getting the steroids, since because it's toxic to your cartilage. We already knew that. Ultimately, can increase your rate of progressing to a replacement. Versus obviously with regenerative medicine, we're trying to actually, you know, hopefully regrow a little bit of stem cartilage. It's not regrowing a normal thickness, but even just recoating it can help if you have areas that are bone on bone, and calm down some of that inflammatory pain in that joint. Because, like I said, people will walk in with. I remember one patient in Minnesota we X-rayed both knees, only one of them hurt, and the one that hurt was not looked normal, and the one that didn't hurt was bone on bone. And so, the surgeon would have just said like, "We'll inject the one that doesn't hurt, and we'll replace the one or we'll inject the one that, you know, um, inject the one that looks normal and replace the one that doesn't hurt," would be the kind of typical solution for that, which obviously doesn't make any sense. So there's more to pain than just like what the cartilage looks like, or if you have some meniscus tears, you can get an MRI of somebody on the street. 50% of people over age 60 have meniscus tears and no pain. So you don't need to get those cut out either, unless it's catching, locking, mechanical symptoms, like there's a pebble in your knee. Those we send out for surgery, but most degenerative meniscus tears, there's strong evidence not to cut out that section of meniscus, which is the most common orthopedic surgery in the country, is a partial meniscectomy, that it actually increases your progression to arthritis. And then the other thing that you're kind of asking about is like your tendons. So like tennis elbow, stuff like that, putting cortisone in those to try to calm down pain. Same idea, it's toxic to your tendon. So you can calm down the pain for 3 months, but it's actually worsening that tendinopathy. When you look at it under a microscope, the health of that tendon is actually being degenerated by that process, versus regenerative medicine actually repairs that architecture of the collagen fibers. And so it's been shown to be superior to steroids in the long term. So if you do a short-term study, look at it for 2 or 3 months, the steroid's better than the platelets because cortisone calms things down immediately and wears off after 3 months. Versus if you look long-term out, 3 months, 6 months, 12 months, platelets are superior to that over those time frames because it's actually repairing it, rather than making it worse. And then the other place that cortisone is used a lot is epidural steroid injections, which are commonly used for back pain, disc pain, sciatica, stuff like that, where we use X-ray guidance to inject high dose steroids right around your nerves and discs. So epidural, is the space around your nerves and discs. If you were to have a baby, they put lidocaine in that space, and then you can't feel your legs or move your legs until that lidocaine wears off, right? Get a C-section. Um, if you go to a pain clinic, they'll put cortisone in that space, just like you would in your knee. The downside of that is that every time you do one of those is a 30% increase in your risk of a compression fracture in your spine. And I'm sure Dr. Chris has seen a lot of people with chronic pain after compression fractures. They're the worst. There's no good treatment for them. They used to put, cement in them to try to stabilize them. Now they don't even recommend that as a first line unless it's become chronic, severe, debilitating pain, because the cement itself causes problems. And so that's a pretty good reason to avoid epidural steroid injections, unless you need just one of them. The time I send people out for those is if you know, woke up or you were lifting something, you felt a sudden pop. Now suddenly you've got 11 out of 10 pain going, burning, shooting down your leg. You can't get off the couch. You know, maybe Dr. Chris tried some traction or modalities or something on you, and you're just like, I can't survive with this. I'm gonna cut my leg off. I can't walk into the clinic. Fine, maybe go get one epidural steroid, see if that can calm it down enough. Maybe it'll go away, and you can work on the other things to stabilize your back to allow that disc to resorb. But otherwise, for like chronic pain, that's not a good treatment because of those side effects and the long-term efficacy of you're turning off an inflammatory process when most people's pain is no longer inflammatory, unless you've got rheumatoid arthritis or, you know, something else going on. For the most part, it's, you know, degenerative. It's a bulging disc that's pushing on something. It's not an inflamed nerve, it's a pinched nerve.
Yeah, so I'm gonna ask you two things. We'll talk about the first one second, standard of care, which you kind of touched on, but I think people should understand the difference of acute and chronic. So, you know, if you go out and have acute pain, you hear your back pop 10 out of 10, but Dr. Nate is saying that there's a lot of efficacy for the cortisone injection at that time. But what you have to realize, if you keep going to that well, not only is it going to destroy your health, it's going to destroy the integrity of your joints because you're numbing the pain and you haven't changed the mechanism for it, and you're going to degenerate yourself faster. And I will tell you that what leads to compression fractures very rarely, unless you fell off down an elevator shaft. A lot of them had chronic pain long before that, and they would take cement and pump it into your vertebral body to jack it up. And I would always wonder, I'm like, is that good for you? Like, is it just stay in the bone? Because bones are porous. And, you know, what the newer research with Dr. Nate is saying, it's actually leaking out. So thank you for sharing that context.
Or just people continue to have pain afterwards. So yeah, there's a risk that it leaks out and, you know, be paralyzed or something. I mean, that certainly is possible, but even just continue to have pain, even though you've made it look normal on the x-ray. So that's why they don't go to that first line anymore. If you go into an interventional pain doctor and say, I just had this compression fracture, what should I do? The doctor would say, here's a brace, take it easy, hope it gets better soon. Because studies no longer recommend putting cement in unless nothing is helping and it's now a chronic pain. But yeah, you want to avoid being in that situation because they can be very painful and there's not a great treatment for them.
Yeah. Earlier in our discussion,
So that's why I don't put cortisone in people's spines.
Yeah, that should be a bumper sticker.
Yeah.
Seriously, but earlier you had mentioned insurance and elective care, and then, you know, it seems like cortisone injections have been the standard of care for a long period of time, and carriers or the medical field not maybe recognizes as much as what you do. Like, where's the gap for that? And why is this not the first go-to?
Yeah, so steroids kind of got grandfathered in as far as like being covered by insurance without having evidence for them. You know, there's actually evidence against them, like we said, for like knee arthritis and stuff like that, where we know that it makes you worse. But those have all been recent studies, and you know, in the insurance system started after what, like World War II, I think. People were coming back and they needed ways to try to recruit workers to jobs, and so this idea of having a workplace provided insurance company was as a way to give a benefit to try to retain and workers when they were in short supply. And so that cortisone was around before that. So it's always just been what we do for pain is put cortisone on it. It wasn't until recently that like they started doing studies on it. And it's not in any position to get its coverage revoked just because of some negative studies. Um, you know, regenerative medicine is in a tough space in that um, one, it's hard to do a large randomized control trial like you would for, say, a pill, where Pfizer knows they're going to make $1 billion off of this pill. If they can get it approved, they'll spend $250 million to fund a massive study to try to find a 1% improvement to justify it. Versus this stuff is your own cells. You know, there's no big players in it. Even Regenix is a large physician practice, but we're still just that. We're small individually, privately owned clinics with, you know, 2 doctors here in Asheville using your own cells. There's no $1 billion profits for anybody involved. And so it's hard to do the kind of study that is expected at this point for pills. surgeries are what is probably more similar to, as far as being able to randomize and blind someone. You can't blind someone to a bone marrow harvest. Um, but even like sham surgery, studies of sham surgeries is pretty rare too. A lot of the surgeries that are done are just prove safety first, and then just start doing it, and those are still covered. Um, Part of the problem is that this is elective too. Just like a knee replacement is elective, stem cells are elective. You could just suffer through your knee pain and not do hikes anymore, and let that happen. And that's kind of what insurance is hoping happens, right? Is that you try some steroid shots, they're cheap, maybe they work, maybe they don't. Hopefully by the time you get a replacement, you're on somebody else's insurance plan because it's cheaper to just keep doing steroids. Medicare is kind of the main ones that decide what gets covered. And that's a whole can of worms for them to say we're going to start covering, stem cells or platelets. Um, because if you're over 65, I mean, you hurt everywhere. And so what's the limit? If Medicare is going to cover stem cells, yes, I could put them in both of your knees, both your hips, both your shoulders. I could do platelets all up and down your spine, and you could do it every couple of years whenever pain starts to come back. Like if money were unlimited, that's what we would do. Um, and so that's for Medicare to write a blank check on that and say, yes, everyone over 65 can just start trying to turn back the clock throughout your body. That would get really expensive. So, versus knee replacements and spinal fusions, nobody wants. You don't do that until it's end stage. Versus like can be preventative. I've treated, both of my knees, both of my thumbs, my right ankle. So, I mean, you can do it anywhere along the way. It works for mild to moderate symptoms better than it does for bone on bone. So where do you draw the limit as far as what is kind of elective stuff that you should pay for yourself versus what is something that we should be providing automatically to everybody?
Yeah.
It's
Well
a tough
said, Nate. I
question.
mean, I think prevention is worth a pound of care. And people often come in here, and I'm sure you've heard this too, like, oh, I got this bad knee from high school. I'm like, well, what are you going to do? You're going to go to Costco and replace this thing? And, when I first got into sales, I was doing orthopedic devices for knee braces and osteo unloaders. And I was putting knee braces on people who had total knee replacements. I'm like, how is this possible? But what happened is, because, like you said, they just stopped moving, they stopped hiking, they accepted less for themselves. They got so deconditioned that they couldn't even do the rehab for the procedure they got, and they got worse. So, they went to an end stage, but they didn't set themselves up for success. And, that's where my practice focus and also regenerative medicine is trying to nip things in the bud so they don't become a big problem.
Yeah, I think that, should be the future of the way that medical care is provided. I just am not sure that that's going to happen with a fee for service insurance based, system, because it's not the same group that's bearing all of those costs. It shifts every time you change jobs, and then the government takes over when you're 65, but nobody along the way there is really incentivized to do preventative care or something that's more expensive than a steroid shot.
Yeah, I think it's dangerous to let any third party dictate your health and your choices. I think insurance is good for catastrophic issues, but as far as like wellness and stuff like that, I think you have to take that into your own consideration.
Yeah, I
And
mean, like naps and massages and stuff are all good too, but they're not paid for, It's,
exactly.
there's things we as a society have decided are preventative things that's on you, and I think this is probably going to end up being one of them, just because it would be expensive to implement
Yeah.
at the level of Medicare.
Well, I kind of like it. I think it there should be choices in life, and people that value their health as their best asset, this is a gold medal play for them to, not only keep their spine and joints moving, but keep them healthy, and nipping things in the bud because there's really
Yeah.
no
I mean,
alternative to
there's
that.
also this idea that people kind of inflate, like if it's covered, it must be good. If it's not covered, it must be experimental and not good. And your insurance company is not, necessarily just trying to do what's best for you and deciding what is or is not covered. And there's plenty of things that are helpful and are evidence-based that are not covered for like these other reasons that we've talked about. And there's plenty of things that are covered that are detrimental to, I mean, like microfracture surgery is covered, they poke holes in your bones to have your bone marrow leak out onto it and try to grow cartilage. Like has not played out. It doesn't do very well. But it's like this thing that's been done for 20 years, and so they're still covering it. Um,
They were paying out big
Obviously it
bucks for
makes
that
more sense for
procedure.
us to like actually take your bone marrow out of a bone that doesn't damage your joint on the way into it, and then concentrate those stem cells and inject them onto the surface. So you're getting concentrated cells rather than just, a couple cc's of unconcentrated bone marrow. Obviously, this is superior, but there's a lot of momentum in kind of how things are paid for, and that's what determines how medical care is delivered,
Yeah,
unfortunately.
unfortunately, being on Main Street, I deal with a lot of entrepreneurs in my practice, and some of them are indoctrinated from that World War II model of have incentives for healthcare and things like that. But when you hear how much their premiums cost them, tens of thousands of dollars and the huge deductibles, but they're never going to meet when you could take half that money and invest it into your health and like what we're talking about and get the other half to your back to your employees, your family, invested in your business. You turn up ahead, and a lot of people are like, "Oh, well, insurance covers it, or my I have a copay," but they don't look at the dividend that's coming out of their paycheck. They're actually paying for that, and there's someone on the other side saying, "We don't want you to get this money that you paid into for," which is another battle all onto itself, which is totally ridiculous.
Yeah. No, don't get me started. I mean, I've got a $12,000 deductible on my health insurance, so I don't go in for anything. And I would just let things, get worse until I couldn't. So it's definitely, if you're looking at, what you can do to prevent those kind of high dollar surgeries, this is definitely money saver. The other one is just time off. We treat a lot of like laborers, farmers, people that need their bodies. And if you have to take, 2, 3 months off after a surgery, that's money unless you've got a good, disability insurance. Um, versus regenerative medicine, you're laid up for like 2, 3 weeks after, 5 weeks return to sport. So it's much quicker recovery, which in some cases transfers into dollars too, or doing 6 months of physical therapy afterwards to try to like fix your frozen shoulder that you got from doing a shoulder surgery, versus, be laid up for 2, 3 weeks and then be right back into it, do physical therapy because it's still good, but you're not having to do it for 12 months. So those kind of things can kind of save money on the periphery too, versus going big, and then being surprised that bills keep trickling in.
Yeah, what I've realized too is, as much as I love my practice members, their time is way more valuable outside of my office. So anything that we can do to expedite the care and get them a better return on investment, they're very happy because, like you said, the farmer and people that work in performance-based lifestyles, they don't have time for downtime, and this is a great opportunity for them to get their life back and not limit themselves of not being able to hike or do what they love to do in their free time.
Yeah, it's a much quicker recovery. That's one of the benefits of this, and that's what keeps people from also getting things like frozen shoulder or, if you're in a boot for a month and then you're surprised that your Achilles tendon is shortened and you can't walk right. So we get people out of slings and boots much more quickly than a surgeon would be able to because we're not cutting tissue, or after a fusion, something like that. We're not having to cut through all of your paraspinal muscles to get to those areas. We can just do an injection in the joints, in the ligaments, and just restart that normal kind of healing response, but actually directing it to all the areas that are degenerated.
Yeah, I don't think people understand surgery what it takes to go through the layers of anatomy. Could you maybe speak to that disruption that occurs and what some post-op complications look like versus getting that injection? And also, we utilize a similar technology in both of our practices with video fluoroscopy, and we kind of touched on earlier with the piston approach. But how specific can you really be in your procedures when people come see you?
Yeah. So, all of the injections that I do are image guided. So you can see the needle, you can see where the needle's going, whether that's into a specific tear in a tendon or ligament, or into, a specific tear in a meniscus, or into a specific joint, even those tiny joints in the back of the spine, the facet joint, you know, the pain clinic, the insurance-based treatment for pain arthritis in your back is what's called a medial branch block followed by radio frequency ablation, where they burn the nerve to that joint. And so they numb the joint by killing sensation to it for 9 months, until that nerve regrows. And then you have pain in that joint again, and they just burn it again every 9 months. The downside being it's also burning a motor branch of that same nerve that gives muscle control. So you lose muscle control at that level of the spine. And when we get MRIs of people that have had several of these, you see that muscle just atrophies away and gets replaced by fat, just like if that arm was in a cast for 9 months. Problem is when the nerve regrows, you can't necessarily regrow muscle if it's already completely wasted away like that. And they don't really do, injections into facet joints because steroids haven't really been shown to be all that effective for it, and it's really difficult. It takes a lot of time to, I mean, those joints are 2 or 3 inches deep in your back, and they're the size of your knuckle, and they can be full of arthritis. And so it's technically difficult to get those injections done, even with the X-ray guidance. And so it's much quicker to just burn the nerve. That's a procedure that takes 10 minutes. And reimburses a lot more. So that's kind of the way that all of healthcare has gone. This is another example where it's just like everything is determined by what's paid for. Um, that's your treatment for facet mediated pain in the back itself, is to burn the nerves to the joints. Versus with the X-ray guidance, we can actually, I mean, they could too, but they don't because they don't have platelet product available to them. But since we have the lab on site that we can actually make enough of this PRP to inject into each of those cells, and we take the time to do that, we can actually treat the arthritis itself. Just like you could do a knee injection with platelets, you can do back injections with them too, if you take the time and have the skill to get them in those deep joints. As far as surgery goes, yeah, they have to cut a lot of muscles, tendons, and ligaments to get into those areas, even minimally invasive type things. They're still having to disrupt ligaments, even those spinal devices that you used to sell, that they put in little spacers between your spinous processes and stuff like that. I mean, that's disrupting. If you look up like supraspinous, interspinous ligament, you'll see you've got this row of ligaments that goes up and down your whole spine. And if you were imagine you're like four-legged, you're on your hands and knees. It's like a suspension bridge. These fibers are basically like holding your back together. Um, and when you can go in and do a surgery or put one of these spacers in, but you just cut a line right down the middle of all those fibers that went up and down from your tailbone to the back of your skull. And you can't think that you didn't also disrupt how those fibers were trying to cross that area. So we try really hard not to disrupt any of those. And that's actually a big part of what we're treating with platelet plasma treatments in the spine, is those ligaments that are holding you together so that you're not having that extra movement. We can do that in the sacroiliac joints. We can do that up and down those posterior, supraspinous, interspinous ligaments. We can even treat like ligamentum flavum, which is the one that's more inside your spine that can get big in response to those ones on the outside not doing their job. That little one on the inside says, hey, things are loose. I'm going to pick up the slack, but there's no room in there for it to pick up slack. And that's how people get spinal stenosis. So our, treatment of spinal stenosis is to stabilize those ligaments on the outside and even to inject that one on the inside to try to shrink it down, because when it tries to pick up the slack, it gets bigger, but it's also like disorganized. Those collagen fibers are not this like thin, streamlined, just like if you had tennis elbow, if you scan it with an ultrasound, you'll see those fibers are no longer like this. Now they're kind of just every which way, and it gets bigger too. And so that's kind of how this stuff works, just like in an ankle sprain, just like in tennis elbow, just like in your spine. Reorganize those collagen fibers into strong type 2 collagen, and that shrinks them down in the process, actually, which can help with spinal stenosis.
Yeah,
And then we
excellent
also do those
response.
epidurals. We can talk about that if you want.
Yeah, let me ask people, bring this into perspective for people. So, every time if you went out to start your car, would you just burn your engine, or you would maybe want to do a little diagnostic and see? And, we know that we have our spinal column here and the nerves come out. And what Nate was saying, people, is they're actually going in there and cauterizing the nerve to kill it. And then as the nerve regenerates and your pain returns, or cutting it again, they're actually cutting it to decrease the sensation, but it doesn't correct the problem. And just think about your spine like this. There's these little joints on angles called facets that allow the spine to move. And what Dr. Nate was saying is these are huge pain generators, and a steroid shot isn't strong enough to get in there, but we can restore the tissue and then restore the motion back to the spine and get a better result. And what we'll see in what we typically see in spine surgery is a buckling of that ligament that is right next to the spinal cord when we lose the height of the disc. And when they go in there, they're just going and cutting the ligament out. Surgeons used to pull it out and show me, like, hey, look, ligamentum flavum. They're just cutting this all out, and then the spine is designed to move. What Dr. Nate is saying, it has all these structures like a suspension bridge in different angles and how to pull and twist and turn, and that allows us what we're doing. But if we put a rigid structure in a semi-rigid device, we're putting so much more stress in that area, and it's actually a part of your body your brain loses control of, which is even more dangerous down the road. You were going to talk about the epidural like you did earlier?
Talk about what?
Epidural, I believe.
Yeah, that was just what I was thinking, since we were talking about spinal stenosis, and bulging discs and stuff like that. That's a big one that gets people in. A lot of times I only see like the husband when the wife is tired of hearing about, complaints because people don't want to go in and get things done, don't want to see a doctor. But radiculopathy sciatica is one that gets people in, without a spouse telling them to get in. Yeah. There's burning pain down my leg whenever I bend over. That's the one that we talked about, the cortisone shots in the back that are so common. We will here do regenerative medicine, the same kind of injection technique using the X-ray guidance into that same space, but using platelet lysate epidural, meaning the growth factors that were inside of those platelet cells, injected into that same space around your nerves and discs, can actually relieve that nerve irritation down the leg by increasing blood flow and kind of health to the nerve itself by right where it's being pinched by the disc. So it actually responds better than to cortisone epidurals in some head-to-head trials, without the side effect of destroying your bones. And it's also been shown to help shrink discs down. So when a disc is bulging, there's fibers all around the outside of that disc called the annulus fibrosus, and those are collagen fibers, just like what makes up your ankle ligaments or anything else. And by getting growth factor right up against that, that can help tighten those up, which will again reduce that bulging effect. Versus, if you have a disc bulge and they want to do a discectomy where they go in and they cut out part of that disc, that's like having a bulge on your bike tire and just cutting the bulge off. Like that's going to then have a normal tire afterwards. So we want to maintain the integrity of that disc whenever possible, and stabilize the outside of it so that it can. I mean, the natural history of those two is even if you did nothing at all, eventually they're going to shrink up and dry up and tend to become less painful over time if you can get through that initial phase with whatever conservative care that is. If it's, chiropractic, exercise, time, even if you have to take, rest it for a little while. Eventually, the sciatica tends to get better as the disc shrinks down. But problem with the disc shrinking down, then as it dries up, is that that disc was a spacer, and so as you lose that spacer, you're now loading those discs more too. And so what we tend to find is that end stage disc disease, even if we do a discogram and pressurize that disc, you don't feel anything from that disc anymore. It's pretty much gone. But you now have facet mediated pain because you're loading those joints extra. Um, and so our goal is to try to maintain the disc height as part of that. And that's what we found by doing these epidural injections, is that it can help with pain down the leg, but it also helps support that disc shrinking back in as far as the bulge, but not necessarily shrinking in height, which is pretty remarkable.
Yeah, I think that's
and
super
that's without having
powerful
to
for
inject
people.
anything in the disc as well.
Super powerful for people to understand, because the body's not designed to be healthy; it's designed to heal. And if it's not, we always have to figure out why. And just because the pain went away, like you're saying with this disc injury, yes, but it's leading you as a increasing the likelihood of some other problems down the road and creates this crazy cascade. And what Nate and his technology and what they offer, just so people get it, they're actually taking your own healing properties from your blood, spinning it down into a matrix, and under guided imagery, able to get it close to the joint line, the ligaments, and the tendons to give it the best chance to heal, but also prevent the initial thing from happening and any other future things from happening. Is that correct, Nate?
Yeah, I mean, in this case, we're talking about the epidural will get it around your discs and your nerves, and then if we think about more of the whole cell platelets for the joints and the ligaments, and so that's kind of able to get both, the underlying cause of the degeneration as well as the symptoms of the degeneration currently.
Yeah.
We can kind of get at both of those by treating what's called the spinal functional unit, which is that same idea we talked about, kinetic chain, where everything that's moving is affecting something else that's moving. Your spine is all connected to each other. There's no one level that's the problem while every other level is fine. They're all pulling on each other. And so that's how we approach things in regenerative medicine for spinal care, is actually trying to stabilize every joint and ligament in your low back, because they are all pulling on each other, and that's what can prevent kind of some of that long-term degeneration.
Yeah, I'm sure people come into your practice with all different, having primary issue or having other collaborative conservative care. Where in like the syntax, you know, if someone's coming in with like, if you look at their pain on their arm or their leg from a lumbar disc, would you like to see them get some chiropractic care and then do what you do, or start what you do fresh and then get the chiropractic care once that heals? Where does that fit in?
Yeah, so I don't usually recommend regenerative treatments in the first 6 weeks after an injury, because your body is already trying to do that same process. If you sprained your ankle, your body sends all that swelling down to that area, and it aches and throbs, and that's your body sending your own platelets to cause this inflammatory response to try to tighten up those ligaments. And that process takes about 6 weeks. So I would say don't take ibuprofen, because that's just going to block your own healing response and make it more likely to be a chronic pain source, which there was a recent study that actually showed that ibuprofen type medicines lead to a higher risk of long-term chronic pain. Um, and there's another good one that looked at like athletes, like weightlifters. They actually biopsied their muscles after exercise, and they looked at people that took ibuprofen before versus ones that didn't. And exercise is a process of, break down, build up, break down, build up. And that's how your body builds, is through this healing response after each injury of exercise. And if you're just eating ibuprofen all the time, you're blocking that buildup process, and that shows even when they look at your tendons afterwards. So my main advice to anybody is, ibuprofen is really just for like menstrual cramps. If if you can, anything else, like if you're taking it for arthritis, tendonitis, back pain, like you're blocking your own healing response, and that stuff's toxic to your blood vessel linings, which is why it's bad for like your stomach. You can get stomach ulcers, but it also increases your risk of high blood pressure, strokes, and heart attacks. So ibuprofen is not good for musculoskeletal issues. Tylenol would be your over-the-counter choice, because that works on your brain and it doesn't block healing. But yeah, so I usually, let people just do kind of the standard of care stuff the first 6 weeks, rest it, use a brace if you have to, do some rehab, get back into things. And then if it's still a chronic pain, we can restart your body's response that it was doing initially, to get you the rest of the way there. It's just like if you sprain that ankle and it doesn't heal all the way after your first round, you might still have a loose ankle. It gives out on you sometimes. And then you end up with arthritis in that ankle because it's moving around too much. This is that you can extrapolate that to the whole body, of this idea of excess movement causes wear and tear. Um, and that your body doesn't always heal things all the way the first time. And so that's just what we're doing, is getting blood flow to areas that don't have good blood flow by actually concentrating the important parts of the blood and injecting them into those areas.
Yeah, I love that you're honoring the body's natural healing response, and it's so interesting that you mentioned the 6 weeks, because that's usually when people come in acutely, how we're managing what's going on with them, and then monitoring that healing. And then if they're not, then we know that we need to get something else on board there to assist them in that, so it doesn't become chronic. A lot of times we
Mm-hmm.
have people that show up that have had previous back surgery, a ton of arthritis. What does a round of care look like that when they come to see you?
Yeah, so if you've had a peripheral joint, or you've had your knee replaced, you've had your hip replaced, and it still hurts, there's not a whole lot we can do for that. You can't regrow cartilage on metal and plastic. Sometimes there's tendons that are still there around the outside of the joint, like that pes bursa tends to be a painful one in knee replacement people. Sometimes hip replacements will still have that glute med tendon on the outside, or the femoral nerve over the front that can still be painful that we can treat. But otherwise, you just have to follow up with your surgeon and hope that he doesn't recommend another surgery. Back surgery is a unique one, like we said. That level that was fused isn't moving at all, and nothing's going to make it any different. But a lot of people tend to start, feel good for a couple of years and then start to get the pain above and below from that adjacent segment disease. We can treat the adjacent segments to try to stabilize those so that they can handle those stresses better. And then we can still do those epidurals if you have nerves that are still pinched. Usually they're not pinched anymore at the level that they did the surgery. That's why they did the surgery, but you still have usually some issues above and below it. or you will eventually. And so that's something that we can still treat with regenerative medicine. But that's tough if they've already had those surgeries. Sometimes we end up having to send people for things like spinal cord stimulators, even for some of those failed back surgeries. That's honestly what I've seen some of the best results with, um, which I don't do. But I always get people to where they need to be, and that's been part of what I try to. Well, one is give people a clear diagnosis and candidacy and all their options, and two is if I'm going to be recommending something else to give you a name of someone that's doing those things responsibly. So I've definitely gotten to know this Asheville community and have people to send you to if you need some of those insurance-based things.
Yeah, well, I think that's great, Dr. Nate, that you have conscious and you do what you can for people, and also have a next steps for you if it doesn't fit with what you do. What does your ideal practice member look like? I know earlier it's mentioned some athletes, and we've kind of talked about acute and chronic. Like, where do people fit
Yeah, I
in?
mean, so being chronic is not really an issue for most of these things. Like I said, the Prolo, we had those veterans from Vietnam that were still getting better from Prolo. So um, we talked about that the hip doesn't do as well. So bone-on-bone hips, we still send out for hip replacements. Bone-on-bone knees is no problem. There's some of the best evidence in all of regenerative medicine for bone-on-bone knees. So that's not really an issue. Um, and we can
Shoulder?
talk. I don't know how much time we even have, but
You got about 9 more
shoulders.
minutes here.
Yep, shoulders. I mean, tendonitis of the rotator cuff is like a big one. Partial thickness tears of the rotator cuff. If it's a full thickness tear where the two ends are not opposed, you can't lift it at all. We send you in for surgery for that to try to pull those two together. There's still risks of re-tear, especially if it's a chronic injury or if you're older. Um, but that tends to be one that people will still get surgery for if it's full thickness, but that's rare. Most cuff tears, even if it's full thickness through like part of it, it's a three-dimensional thing. So it might be full thickness through the middle, but there's still, fibers on either side that are anchoring. It's not retracted. We can still fill that in with stem cells and get good results. So we always look at the MRIs ourselves. We'll scan you with an ultrasound ourselves to see what the actual tendons look like. Age is not an issue as far as candidacy grading. Just for that hip, over 65 makes you more of a poor candidate if it's bone on bone. But anywhere else, there's been no correlation with age and outcome in our registry data. So we've tracked the outcomes of all the patients that we've treated since 2005. So we got 18 years of data on kind of who's responded and who hasn't, and there's been no correlation with age or BMI. So even being obese is actually does not mean that you won't get better from these things. We count how many stem cells we get out from every bone marrow harvest that we do, again, in part to try to correlate, like, why did this person not get better? Was it because the harvest wasn't good enough? So we know we need at least 400 million nucleated cells per joint to get a good outcome, and we routinely get like 1.2 billion, so like 3 times as many cells as we need. Is kind of a typical bone marrow harvest for us. And that doesn't drop off significantly with age. So that's another thing people were, oh, I'm old, you're using my old stem cells on me. Don't I need, umbilical cells or something? And no, you still have a high numbers of stem cells in your bone marrow in the back of your pelvis. Yes, they do drop in your knees. That's part of why you develop wear and tear in those peripheral joints, is because your numbers decline peripherally with age, but you maintain good stores of them in your pelvis. And that's where we get them from. So we're doing a transplant from where you've still have good stores to where you've lost them and you can no longer keep up with wear and tear. Yeah, poor candidates, smoking, diabetic, alcoholic, anything that keeps you from healing well or relying on your own healing response. And so if you're otherwise healthy, you have a good diet, you're someone who has, they call good protoplasm, basically means like you're someone who heals well and isn't kind of falling into this um, chronic illness picture. That'd be someone who would tend to heal better and respond better to these treatments.
Yeah, I think that's a great motivator for people to take care of their health as the best asset, knowing as you age, things are going to change. If you hear what Dr. Nate's saying, he's like, the pelvis is still viable for health, but the knees are going to wear out. But if you have these other risk factors, you're limiting the options that you have for yourself. It's like getting a haircut that doesn't grow back, right? We don't want to put ourselves in that position. As we get ready to close up here, Dr. Nate, if you could let people know where you're at, and I think we have some questions for people where else they may find someone that does something you do in their part of this other parts of the country.
Yeah, so our clinic is called Asheville Regenerative Orthopedics, and it's in Biltmore Park in Asheville. There's two doctors there, myself and Christy Lehman is the other. She's also physical medicine and rehabilitation, subspecialty trained. And we're a part of this larger Regenix network. So we're all doing similar procedures across this network. That's where I'm saying I've been with them for 6 years. That's the group that's been tracking those outcomes for 18 years. And so you could research through them as well to see kind of what we're doing with regenerative medicine.
Yeah, I think the nice thing about Regenix, like Dr. Nate is saying, they do research and they post blogs that's connected to the research, so it's super informative for the help for the efficacy and to find people in your area. Anything in closing you want to share with people?
No, I think you're doing all the right stuff, just trying to maintain what you have, don't lose it, don't overdo it. I mean, I'm 37 and I'm always trying to, strengthen those little muscles that hold you together and not people make fun of me for like carrying a backpack on the front when I'm loaded with like two bags instead of having them like on one shoulder and walking around like this. I'm like, no, I want to be like balanced, like you were saying, that front side, that side to side, that gluteus medius, for the runners, like work on that core strength. Ability to stand on one leg is correlated with longevity. So work on that. There's not a lot of things we do in medicine that are directly shown to make you live longer, like beta blockers in people who have had heart attacks and the ability to stand on one leg. Those are like the two things that we know make you live longer.
It's funny you say that. Everyone that's been through my intake, we all do a single leg balance, both to test the axial
Yeah.
structure, but also the cerebellar function. And you'd be
Yeah.
surprised the people that fail that test have a litany of things wrong with them versus the ones that it will. And it's
And
at
now they
any
know they're
age.
more likely to die sooner too if they don't get that work done. So yeah, protect these. They're not glamorous muscles. You don't need to bench press 200 pounds. You just need to be able to stand on one leg and do a plank, and that's what'll keep you going strong into your 80s.
Yeah, excellent
So
advice.
that's
I
what I'm
agree.
working on.
Yep, I agree. This is the future of medicine, people. Collaborative care, using your own body to heal itself. And I can't thank Dr. Nate for sharing this wisdom today, what he does in his practice and his vision, not only for the Asheville community, but for his entire profession. So thanks, Dr. Nate.
Yeah, thanks for having me.
Have a good day.
All right, bye.